Good afternoon, everyone. I'm excited to be here with you all. As mentioned in the introduction, I am a pharmacist working in family medicine, so I get to help out with chronic disease management. And so I really work a lot with GLP-1s in the realm of diabetes. But of course, as in a lot of areas of medicine and primary care, we're getting a ton of questions and a ton of discussions are happening around GLP-1s for weight loss. And so we will go ahead and dive a little bit deeper. We had an excellent introduction into these agents, but let's go a little bit further in and talk more about GLP-1s. So I think, as was previously mentioned, that bottom of the pyramid that we saw is really, these are meant to be an adjunct to behavioral modifications. And I think it's also really important to mention as well that when we look at a lot of the studies that are looking at GLP-1s for weight loss, many of them are also including lifestyle modifications. So that's something to really keep in mind. A lot of the outcomes that we're seeing are the combination of lifestyle interventions plus these medications. So things like prescribing exercise a certain amount, calorie deficit diet, typically there's check-ins. It's a fairly comprehensive weight loss lifestyle intervention as well. And then also as mentioned, the guidelines are evolving, but currently our guidelines really target BMI. And so we have traditionally thought of these agents for folks who have a BMI greater than 30, so are in that obese category, or who have a BMI greater than 27 plus a weight-related comorbid condition. Generally, we define efficacy for weight loss pharmacotherapy as 5% of body weight at 3 months. And oftentimes you'll see, a recommendation to reassess at that 3-month mark to really determine, are we achieving that level of weight loss? And if not, perhaps consider discontinuing that medication and perhaps considering another one. So we teased this a little bit earlier, but I think the real hype around these medications is the fact that the efficacy is a lot better than what we have previously seen with our weight loss medications. Our older medications did contribute to weight loss, but a lot lower amounts, as you can see up there. I think it's also worth mentioning that many of these medications that we had prior to the GLP-1s had some, comorbid or some side effects, right? So GI-related side effects, fecal incontinence is never a great side effect that you want to see with orlistat. Certainly cardiovascular concerns with our phentermine-containing products. So not to say that the GLP-1s are not without side effects or safety concerns, and we'll talk about those, but I think they've really gotten a lot of hype and a lot of excitement in this realm because they work pretty dang good. And, so far it seems like the safety and tolerability profile might be a little bit better than some of the better agents that we used to use. We had a pretty good overview of how these work. I think the really basic understanding of this is we are mimicking endogenous GLP-1 and GIP, and we're hitting that hypothalamus in the brain, the receptors there, and that final outcome is really to decrease hunger, increase satiety. So patients often describe, I just feel full faster, I'm not eating as much, my portion sizes are going down, and that's really an outcome of this action, which is great. So as far as which medications we're talking about, so we have the 3 that we outlined before. There's, of course, more medications out there and different brand names indicated for diabetes, so type 2 diabetes. These are the 3 that are specifically FDA indicated for weight loss. You'll notice that all of them are sub-Q injections. And we go, typically the 2 that we're seeing more commonly, Wegovy and Zepbound, are weekly injections versus Saxenda is a daily injection. Wegovy and Zepbound have a little bit better efficacy. Well, I shouldn't say a little. They have significantly better efficacy data, and so I think those are more favored typically by providers and by payers. They are started at a low dose and titrated up, and that's really because of the primary side effect with these, which I'm sure many of us have heard of. What have you all heard as far as primary side effect with GLP-1s? Yeah, GI related, right? Nausea, diarrhea, constipation potentially, vomiting potentially, is not uncommon. So we start low and we titrate up. For those weekly injections, we're titrating every 4 weeks. And we might potentially extend that titration period if someone's having GI-related side effects. But we're really checking in on that. And then there is a max dose, which of course is associated with a higher amount of weight loss. So again, we're titrating based on tolerance, we're titrating based on the treatment response to that potential max dose there. I did want to quickly mention, I stated at the beginning of my presentation, 5% at 12 weeks is typically considered treatment success, and liraglutide is slightly different. It's 4% at 12 weeks. But again, I think the key point is really checking in at that 12-week mark or thereabouts to really determine have we gotten the level of weight loss that we are hoping for. There is some safety considerations to think about with these agents, in addition to, of course, counseling on the GI-related side effects. There is a contraindication if someone has a personal or family history of medullary thyroid carcinoma or multiple endocrine neoplasm type 2. So 2 different types of thyroid cancers. That data is really based on studies done in rats. We don't quite know how that translates to humans, but that's something that we're screening for and watching for. Similarly, with gallbladder disease and pancreatitis, we are considering the risks and histories of those things. Hypoglycemia is in particular for when these agents are used in addition with medications that treat type 2 diabetes that can cause low blood sugars, so things like insulin, sulfonylureas. If we're using this GLP-1s in combination, we can see a higher likelihood of hypoglycemia. The other one I wanted to highlight, tachycardia or increased heart rate, is anywhere from 1 beat per minute to 7 beats per minute, depending on the agent. Suicidal ideation is another one that we've recently had an FDA release about, so really watching out for changes in mood and counseling on that. Drug interactions is an interesting one. So all 3 of these warn of the fact that it's really delaying gastric emptying, which could impact the absorption of oral medications. And in particular, I think one that's really interesting to highlight is Zepbound in the package insert specifically calls out the interaction with oral contraceptive medications and talks about how with oral contraceptive medications we could have delayed absorption, and therefore we really need to think about backup methods or alternative methods, and they mentioned for 4 weeks after initiation or dose escalation. So I think that's something to really think about in our patients of childbearing age who are potentially thinking about these medications. And we're going to learn more about pregnancy in our next speaker, but they are currently not recommended for use in pregnancy. What I think is a really important piece of this conversation is talking about treatment durability. So what happens when someone stops taking these medications? And we have some pretty good trials to indicate what's going to happen. So the STEP 4 trial is related to semaglutide. We also have the SURMOUNT trial with tirzepatide. And what we see here is folks who do not have diabetes but do meet the classifications for pharmacotherapy. They're started on a medication, and what they did was they put the patients on the medication for 20 weeks. Semaglutide, they titrated up to the maximum dose. And then they randomized, so folks either continued on the semaglutide or they stopped treatment and went on a placebo. And again, lifestyle interventions were implemented in both groups. And what they found is during that 20-week run-in period, the mean body weight declined by 10.6%, which again is just really incredible outcomes for 20 weeks of treatment. But then when they stopped and they went to the different treatment arms, what they found is those who stayed on semaglutide lost an additional 7.9% of their body weight, versus those who switched to placebo gained 6.9% back of their body weight. So that's not to say that these agents aren't great for weight loss. They are, but I think, again, it's an important piece of the conversation to talk through. What we're seeing is when patients stop these agents, they are regaining a portion of that weight back. Similar results we're seeing with the SURMOUNT trial, the SURMOUNT-4 trial for tirzepatide. So again, it's a discussion of we're really thinking about weight management and obesity as a chronic disease, and these agents, we're thinking more long-term use. Again, though, all part of the larger discussion of the pros and cons of these agents. So I think we really want to select GLP1s for those that are indicated for pharmacotherapy in conjunction with lifestyle management. And consider the side effects, the dosing, the titration, and then the warnings and precautions with these agents. I would also throw in the drug interactions. And then, long-term data is still coming, right? These are relatively new agents. But we also do need to think about that poor durability as far as our overall treatment with patients and long-term goals.